we thought would be edifying for members of the hospital, medical staff, nursing staff. So today we are talking with a few of our colleagues. We have Marty Kelston, who is in our Department of Pathology. We have Rhonda Geiser, who is a doctor in our OBGYN department, and then Dr. Larry Lilly, who is our breast cancer specialist. So no one came here to hear me talk, so I will introduce Dr. Marty Kelston, and he will get us started off. So Marty, you're up.
Good morning. I'm gonna go up here. But anyway, good morning. For those of you that don't know me, because there are a lot of you here that I haven't been a fixture here at Riverside actually for well over a decade. I started my career here in the late 80s, early 90s, and then in the mid 90s I started working over at Grant, and then I've been at multiple places throughout OhioHealth ever since. I cover cases and things in this campus, but I actually haven't really been based here for years. Anyway, I back in 2006, just a little bit over a decade ago, it was my 50th birthday. I decided it was time to get a checkup, and I discovered I was anemic. And being 50, I thought, well, maybe I've got a polyp or something like that. And I eventually got to a doctor who, well, actually, the real story is that I first went to one doctor who did a relatively cursory exam on me and didn't find anything. And then I sort of kept pushing because I was anemic that I needed to have some workup. And after about 2.5, 3 weeks of nothing happening, I decided to go to another doctor. And it's somebody that used to be on the medical staff here at this campus. And he and I went, actually my wife and I went on the same day to have checkups. So she was in one room, I was in the other room, and he examined me first. And about halfway through, when he's doing the abdominal exam, he says, "Why am I feeling the spleen in a 50-year-old man?" And immediately, we're all doctors, immediately I start going, I don't know why I'd have a spleen 50 years old, but of course my brain first went to lymphoma, leukemia, whatever. And so he and I had a discussion about, well, how and what are we going to tell my wife, because she's in a room across the hall. And so he went and did her exam, and everything was fine. And then afterwards, we talked about how we were going to work me up. And so I actually had a CT scan later that day when I went and walked into my radiologist friend, and they showed it to me, and I had the spleen that was comparable to the size of my liver, and lymphadenopathy pretty much all the way through chest, abdomen, pelvis, everywhere. And I knew, the radiologist was trying to say, oh, well, it might not be anything, but of course, I knew it was something. And so I got some initial blood work, and my colleagues were, they felt because lymphoma was a possibility and the blood count was normal, they thought, well, let's do flow cytometry. And so by the next morning, I knew I had mantle cell lymphoma. And so I think that's it's exemplary of what can happen with us as physicians, because we sort of have an inside track to a lot of things. We know what's going on, all that sort of stuff. We will have people that are our contacts we're able to get information from very quickly. But at the same time, you're sort of trying to deal and process it all in your head at exactly the same time. When we told my wife, she was, needless to say, pretty upset, and we spent a lot of that day and that evening trying to think about the steps toward trying to get an answer and figuring out how to proceed. So I believe that was a Wednesday. Thursday I got the diagnosis, and I went to see an oncologist the next morning. Actually, my wife and I are walking from my office at Grant over to the Wilkins Medical Building, and anybody that knows Grant, there's a walkway there above 6th Street, and I'm walking across that, and I see one of my surgical colleagues, and they said, oh, I've heard, how are you doing? I said, I'm fine. And she said, well, what kind of lymphoma was it? And I said, or is it? And I said, mantle cell. And she goes, oh. and back then it was a fairly serious diagnosis to get that. And I knew that, and a number of people did. So, but I, tried to tell my wife that, well, there were a lot of options for things to do and things to be treated, whatever, but I was trying to manage her at the same time that I'm just trying to deal with my own feelings. And then as we walked away from that interaction, my wife goes, what was that? Because, what was that interaction with her saying, oh, that's too bad? And I told her, well, mantle cell lymphoma is not a particularly favorable type of lymphoma to get. So anyway, got my initial workup. We had a bone marrow, talked about all the different options, different protocols. At that time, there were only a few places that really specialized in lymphoma and mantle cell lymphoma. It's one of the more rare types, and the two main places were at MD Anderson and Memorial Sloan Kettering. I was, my wife's family's in New York, so we had interest in going to New York. And so we went out there. I went to Memorial, saw one of the leaders in mantle cell lymphoma, and their protocol was that you started with R-CHOP, and then they assessed you, and if you were clear of disease, then you moved on to the next cycle, which was called RICE, which is Rituxan with 3 other drugs. Rituxan is anti-CD20, and then that was all preparation for them collecting your stem cells and then undergoing autologous stem cell transplantation. And so I had BEAM for that, which is a fairly rigorous set of drugs. The R-CHOP was really relatively easy to tolerate. I had a little bit of nausea and I'd feel a little fatigued, but it wasn't that bad. The RICE was an inpatient set of drugs, and that was pretty difficult. I really felt pretty crummy the whole time. The line is, they say, well, you'll feel like you have flu. Flu doesn't even describe how awful you feel. So it was really pretty awful feeling. And it took me probably about 2 weeks to feel better after that one. And I had 3 cycles of that. So the final cycle is when they collected the stem cells. Collecting stem cells is pretty much like a platelet pheresis. They just hook you up the same way and collect that portion of the blood from the draw, and then feed you back your red cells, and then they collect that and hold that for you. So then they give you the actual treatment for the transplant, which was extremely difficult. That made me feel really pretty crummy. I was by the end of a week, I was really very lethargic, did not feel well. Initially you don't have that much difficulty swallowing, but eventually you do. And that was more difficult to get through. Day 8 is when they give you your stem cells back, and then I did all this in New York, and then I I started getting my marrow back around 2.5 to 3 weeks out, and then I was in the hospital for another few days after that. So I was inpatient in isolation for all that time. During that time, my wife was the main person that came in to see me, and she, of course, had to be gowned when she was in there with me. So that was interesting having that sort of experience. But basically, if I was in the room, anybody coming into the room had to be gowned, and if I had to go out of the room, I was gowned and everybody else was fine. So that's sort of interesting. But anyway, the recovery phase was relatively easy. I'd say I mainly just had difficulty with exhaustion and, actually, interestingly, temperature regulation. I was always hot and cold, and that was very difficult. But I eventually got my energy back over time. My hair grew back around I don't know, it was maybe a couple months. I started growing it back after then. Some of the other things that happened, stories that were good, were when I got admitted to the hospital at Memorial the first time, my family my kids provided me a poster board, pictures of everybody in the family, and there were the dogs and the kids and whatever, and then there's a picture of my wife and myself. And of course, if anybody that remembers me back then, I had a full beard, big bushy hair, is all gray, and at this time when I'm going to the hospital, I had no hair on my head at all. And so the nurse looks at me and says, "Oh, I see all the people in the family. Is that your father?" And so that immediately at that time I realized I am not going back to that look. So that's why I never grew my beard back. I've kept my hair relatively short since. So that was one. But a lot of people ask you things like, well, how did it go? How did it feel? How, what do you expect during all of it? How do you recover? And one of the things I'll say is that it really depends on how things go. I mean, even though I had ups and downs and I didn't feel all that great much of the time, everything pretty much went like clockwork. And that was, as long as things go as proceeded, you're fine and you're feeling fine and things are getting better. I don't know what it would feel like if I were, going through this and I would have relapsed or I would have not responded. And I think I would have a very different outlook on how things went. So I think that's important. I think another thing is, if you stay within the system here, you're going to see a lot of people but the minute you go out of the system, you're just like everybody else. And that was very apparent when I was at Memorial. I was just like any other patient out there. And even though the people that took care of me knew I was a physician, otherwise I was just another person to them. And it's very important to know that everybody is a person and everybody needs to be treated entirely as though they're the most important person in the world when you're dealing with them. A few things that I've got like pages and pages of thoughts of things I could talk about, but some of the key points I'd want to add would be one, we know the system well, and you get something like this and you immediately, your physician brain kicks into gear. What are the different steps I need to do to get through this? And you immediately get into physician mode. And I just, did my research. I came up with my to-do list. I'm doing everything. And you run into an obstacle and you know the person to call in the hospital to find the answer to it, whatever. I think it's very important to realize that the average person doesn't have any of that at all. And so those of you that know anything about the cancer system here, they've started a navigator system, and I've spoken with Mary Stepanica multiple times. I think every single patient that gets a diagnosis should get a navigator immediately assigned to them, because most people have no idea how to get through the medical system, and it can be very complicated. Getting things paid for, getting things arranged, figuring out insurance issues, et cetera, are extremely difficult. And at the same time, you're just trying to worry about how am I going to get better, and you're worrying about all these other things with respect to how are you going to pay your bills, how are you going to make sure that your kids are taken care of. I think one of the references I left talks about how do you talk to your kids. That was a really difficult thing. That was like the first thing that my wife and I thought of how do we tell our kids. At that time, my kids ranged from, I guess, 12 to 16, and the reference I got was, and I've provided you, it's available online now, is through the National Cancer Society, or American Cancer Society, and they have a reference there that talks about how it really depends on the age of the kid. If they are really young, they don't really understand a lot of it. They just know that you're not feeling well. If they're like teenage, the main thing they're going to be thinking is, what does this mean to me in my life? And how is this going to affect me? And if they're sort of in the middle school age, their entire world seems to have fallen out from under them when they find out. So we sat down, we actually, like I said, it was Wednesday, Thursday, Friday. My daughter was horseback riding that weekend up in Michigan. So I went on the trip with them for that, and we decided we were going to come back and have a family meeting, which obviously, you don't have family meetings every day with your kids. So we sat down, had a family meeting. My two teenage kids are sitting there like, yeah, Dad, when is this going to be over? And I just basically said, well, I have lymphoma, which is a type of cancer, and the two teenagers just sort of sat there totally motionless, didn't really say anything. My middle school girl absolutely fell apart right there, just melted onto the floor and crying with my wife. So it was like they had read the book of how it was. And then this is over a decade ago. Internet stuff was just sort of becoming a little more popular and to look at, and they would look online, and they'd actually the kids didn't really say much at that time, the teenage kids, but then they went up and they started looking online, and then they'd slowly ask me over the next few days different questions of things they learned. So I think those are all really important things. The other quick points I'd make would be psychiatric support, psychological support. I would highly recommend it for anybody that's going through something like this. Anybody that knows Mark Very, he retired a few years ago. He was my psychiatrist. He was a great counsel, and from our point of view, he was also a great professional coach during this entire period. I think he kept me steady in many ways. During the recovery phase, you're extremely emotional. I remember sitting in Central Park one day watching somebody walking a dog that had 3 legs, and I just broke down in tears. So the recovery phase is extremely emotional. The checkups, once you go back, I've heard them referred to as parole visits. And that's exactly the way it feels, because in between times, you may be feeling fine, but then you have all the anxiety of actually going and finding out, well, how are things going at this time and moment. But then the final thing I want to talk about is you get through all this and you think, now, I'm fine. The only thing I have to worry about is recurrence of disease. Well, I actually have two pretty significant sequelae. One was it took me about a year and a half to get back to full time. And once I was back at full time, I realized very quickly I wasn't nearly as efficient as I used to be. I used to be able to keep 3, 4, 5 things going at a time, be able to move from administrative things to clinical things and everything in like no time at all. And very quickly I realized I wasn't able to do that anymore. I was getting further and further behind in my work, and I quickly was finding that I needed to put 14, 15, 16 hours a day, 7 days a week just to get my work done. And again, working with Mark Very, we discovered that this was probably chemotherapy-induced cognitive impairment. And so as a result, I have loss of efficiency. Even though I'm on medication, I work on different skills, whatever, I am extremely inefficient. And it's extremely frustrating. It's kind of like having ADD, so I have to stay very focused on whatever I'm doing on a day-to-day basis, and it makes it much more difficult to get my diagnostic work done in a timely way. My group has been tremendous. Once I went back to them and told them I needed to cut back on the volume of work that I did, they were extremely supportive of me. They've been supportive of me all along. That's incredible support to have that. When you're first coming back to work and you're not sure where things are going, you have questions about your profession and, am I going to be able to do this? Do I want to be able to do this anymore? And that kind of support is tremendous. And then the final thing is I have a cardiomyopathy as a result of the chemotherapy. And that was pretty shocking to find that, because I felt totally normal. But anyway, so I'm 10 years out. Everything's been going well. I feel as though everything is going to go well. And 10 years out, we've known now that mantle cell lymphoma, that there's a significant portion of people that have that kind of a course. But there's a subset of people that don't, and luckily I was not one of those. So the other things, we can talk about them when we have the open discussion, things such as survivorship and colleagues and all that. I think I'm more than happy to address any questions along that line. Okay, thanks.
That's okay. For those of you that don't know me, I'm an obstetrician gynecologist here at Riverside Hospital. I remember the day that I learned that one of our labor and delivery nurses, Christina, was diagnosed with breast cancer. I looked over at her and she was wearing her surgical cap. It's a fabric kind that's made out of material with the pretty designs. And I couldn't see any hair coming out the edges of that cap. I remember I was afraid to talk to her. I was afraid I'd say something wrong or do something wrong. And I was feeling upset and anxious about what she was facing. I was diagnosed with breast cancer just some months after Christina, and I would undergo bilateral mastectomies with reconstruction and 6 months of chemotherapy. And I was getting bad news and more bad news. And I just wanted to drive away. I really wanted to be Forrest Gump. He ran and ran and ran, but I have IT band syndrome, so driving was a better idea. But I would not run and I would not drive. I would face it all. Dr. Paul was threatening to come out of retirement to help us out if I couldn't work. And none of us really wanted that. So my partners needed me and I needed them. And while I know I could ask off for time from work, we saw this as another hurdle that our practice would just have to clear. So I underwent major surgery of bilateral mastectomies. Dr. Paul had had that surgery just some years before me. She came back to work after only 3 weeks because she's hard-headed. We doctors think that we're stronger than the average patient. She went to my partners and told them that I would really need 4 weeks off, and I was grateful because I didn't want to appear weak because I took 4 weeks off from surgery. After surgery, I would have to face chemotherapy. And for those of you that know me, know that I like to wear my suits and my high heels. The nurses know the click of my walk. Occasionally, I've ended up in a C-section in my high heels. But that would all change as I was losing my hair. And I really didn't like that wig. And I felt more comfortable in the surgical cap like Christina wore. But the surgical cap doesn't go with my suits and high heels. So it would be 6 months of scrubs and clogs. And I'm sure that my colleagues appreciated the break away from my clanking heels. But I'm better now. When I went back to work, my partners had thought of everything. Dr. Vanek had scheduled herself to scrub with me in my first few cases. I didn't ask her to do that, she just did that. I didn't even know that she did that. And that is precious time away from her practice and loss of income. And I didn't want to admit that I needed it, but I needed that. We doctors don't want to be the weak link. But I was very grateful that she had the forethought to do this. And Dr. Missy, she took care of my schedule. Another task I didn't want to face. But with her administrative talent, she was able to come up with a plan that was conducive to my chemotherapy treatments and my days of nausea and fatigue. And that's why a lot of you didn't see me on my sick and bad days. And the nurses were so good to me. They would treat me like work as usual with some unspoken concern about my well-being. They would watch my physical activity to make sure that I wouldn't do anything to harm my surgical recovery. And they would try to page me a little less often, wait a little longer, so that I could get sleep when it was possible. And poor Dr. Beth, she would always ask me how I was doing when I was having a particular bad issue. And I don't know if she knew I was having a bad problem or if she was just unlucky to ask me at the wrong time. But she was good to hear me out, and she would. I complained about my running nose. It was so bad I could barely finish a patient appointment before I had to run out and wipe my nose. And my nose was red and scabbed and painful and so embarrassing. And she would hear about the anxiety of the neuropathy. That neuropathy was so uncomfortable, and it was all day long and unrelenting, and it preoccupied my mind. I wondered if I could finish the chemotherapy. I wondered if I would have permanent issues and I wouldn't be able to operate anymore. And even though Dr. Beth couldn't fix anything, just her hearing me speak out my fears and anxiety is what I needed. At night, when I'd go to bed, I had time to think about what was happening to me. I couldn't believe the nightmare I was in. Work woke me from that nightmare because I had other patients and obligations with colleagues and patients. And I appreciated every effort that colleagues made to try to brighten my day. There was a time that the nurses needed to take a picture, and I shied away, and I said, I don't feel so pretty. And Dr. De Leon kissed me on my cheek, and he said, you're pretty. I didn't know he had such a big heart. Did you? And there was a time, an evening, that I was not going to let myself throw up. I am not going to vomit. I'm not sick. I'm fine. And Dr. Minnie came over to visit me, and she brought me a boob cake, nipples and all. I wanted to laugh, but I saw that cake, and I ended up sprinting to the bathroom and proceeded to vomit despite my best efforts. And I felt better. My mom took the boob cake to Bridge Club. I heard it was delicious. Then there's being the patient. I didn't research any of the literature. I know what the literature tells you. It tells you every worst detail, details that aren't necessarily going to happen to you. And I didn't want to know the worst. My husband would read some and give me his thoughts. I knew it was bad when he had done some reading and he came into my office crying. Then I really didn't want to read anything. And we physicians are lucky. We know the good doctors. And so I knew I was in good hands and I could skip the depressing literature. And I did. I also learned more about the doctor-patient relationship. You know how you have that patient, only she wants you to be there at the delivery. Only you can do the delivery. No one else can do her delivery. And you're feeling so guilty. Well, I understand a little bit better now. Dr. Lilly would become God-like to me. He was taking something out of me that was trying to kill me, and he would do it well. When it came to facing patients, there were many different facets. Some patients would think something medical was going on that they were afraid to ask. And some patients would ask me how I was doing or how I was feeling to see if I would offer up any more details. And some patients would call my office immediately after the appointment and ask my staff if I was okay. And some patients send cards. One of my favorite was when I had my favorite encounter was with a long-term patient who was very outspoken and direct. And she had brought her daughter in to see me, and she noted right away my very short, curly hair. And she stated the obvious, "Your hair is short and curly." "Yes," I said. Then she asked, "Why did you cut your hair?" And before I could answer, she asked, "Do you have cancer?" I just started laughing. I knew there was no making up any story with her, and I was just so tickled about her directness, something I'm not as good at as being that direct. And even though she may not have come across as the most sensitive person, she was upset. Some patients cried with me. Some patients preyed upon me. One of my patients left my practice because of my breast cancer. I'm blessed it was only one. I understand that they would fear that I would not be strong and capable. I'm actually amazed that my practice continued to flourish. I tried to use my situation in a way that I thought would best help the patient. I reassured patients that I'm fine if they were worried about me. And I reassured patients that I was strong and capable and I could come through for them for their surgery or delivery. But I think my most important use of my situation was to admit my breast cancer diagnosis to those who had breast cancer that needed to hear it. Not every patient with breast cancer needed to hear it. But some of them just wanted to talk to me, a doctor, in their same predicament. I had one patient that said it was the most that her mom had talked about her breast cancer experience. I also had a situation, or I've used my breast cancer diagnosis situation in a selfish way in at least one, if not more, situations. You know how you have that patient and she's sitting on the exam table, her arms are crossed, she's tight-lipped, she's just waiting there for you to prove yourself. Well, this patient was getting care for breast cancer, and I could feel her cool and untrusting demeanor. Well, I just caved. I said, "You know, I've done what you're doing now." And I went from some other annoying physician to her best girlfriend that she could tell all her secrets to. And I know I feel a little guilty about building a rapport because of my breast cancer diagnosis, but it was sure nice not to have to work so hard to gain her confidence. My point is, are you married to the right group of partners? Are you surrounded by colleagues that can help you plow through those hard days? My partners gave me the support I needed to work. They made me feel like a normal, functioning physician and gave me expectations to make me feel as normal as possible. I knew that I could take off time for work or ask for help without being judged. In your practice, can your partners get you through cancer? And residents, when you join a practice, are you joining a group of partners that can get you through cancer? My work friends made every effort to make me strong, and my good nurses made me feel like a superhero. I know that not every doctor with cancer can work, but I hope that you see that you, as a partner, as a colleague, or as a patient, can help actualize the potential of those with cancer to work. Be unafraid to approach those with cancers. I was so appreciative of so many of you that approached me. And know that your patient can look beyond your illness and see you as a capable physician. And for those of us who have had cancer, we should understand that people just want to help, and we should let them into our dark world so they can bring us light. I'd like to be a superhero. And for those of you that know me, might not be surprised that I'd like to be Wonder Woman. She has an invisible plane that I could fly to work. She's physically fit and beautiful, and she has a great outfit that accentuates her beautiful breast. She is strong and invincible, and she could beat breast cancer. You all made me a superhero. That's enough. Bye. And now I would like to introduce my superhero, Dr. Larry Lilly.
Well, I don't think I've ever felt quite so inadequate. I think Is it on? Okay. But thank you, Rhonda. Thank you, Marty. I knew I was going to be sort of, additional added on here, that this is the main show, and they both did an excellent job. And I think if you listen to them, you heard what you need to know to take care of people who are going through things like this. I got my first advice for dealing with what I might refer to shorthand VIPs, or very special important people, back years ago, probably in the late 70s. And I'll give, Jay said not to use any slides or credits, but I'll give one credit. And John Thomas may be the only person in the audience who will remember, but there's probably a few others back there. But Bill Nuhr was a surgeon here, and he took care of most of the doctors and nurses in the hospital, I think. And I was on his service, of course, and I would see him take care of these, the doctors, nurses, their families. And so he would talk about what you did. How did you deal with that? And what I remember is you treat them like everybody else. You can't have two tiers of treatment. You can't assume certain things. You've got to treat them like everybody else. Now, he would try to schedule first case of the day, and he'd do a few little things like that. But basically, what he was saying is that we are all people. We all will be patients probably at some point, and we all need the same treatment. And so I took that to heart, and I'm both very honored but also very humbled by having you and your colleagues that I do see from time to time. I have to admit that my epinephrine level goes up a little bit when I see, a doctor on the schedule, or a doctor's family, or a nurse. But I feel a challenge that, I need to make sure I treat this person like everybody else, but to make sure that I do it well. I think the first thing I try to do is to prepare myself. When I go in to see a patient, whether it be a VIP or someone on Medicaid or whatever, someone without insurance at all, is I try to know what's going on. The patient, I think, expects us to prepare, and they expect us to sort of, when they come in, they don't want to have to tell you everything. They want to think that you know what their needs are and that you're going to be able to take care of them. So I review the chart. Now with the electronic chart, we can often find information done at other hospitals. We can see everything that's been done. We can find an old biopsy result. And so I go in and I review that with the patient, and I think at least they know that I'm interested in what they're going through and trying to understand, and they can correct me when I'm mistaken. And so I try to communicate that with them, and so that they'll know that we're ready to try to deal with them. The other thing is I do try to do that communication, make sure it's two-way. I've had the misfortune, or perhaps the fortune, of having a family member go through some fairly serious illness here recently. And I realized then how critical it is to feel like people are listening to you and understanding and have your best interest at heart. I work very hard to get the trust of my patients, because the only thing I think I can offer is if they trust me and they have confidence in what I'm doing, we're both going to do a lot better. And so I sometimes say I'm going to be brutally honest, but I will also be optimistic, hopeful, but I won't lie. I have to have the patient's trust in order to take care of them. And I think the other thing that we need to remember, you heard a little bit of the HIPAA issues with Dr. Kelston. We need to remember that we live in this fishbowl called OhioHealth, Riverside, whatever, and that word does travel, and so we try to be very respectful of that. But also it can come up that when different colleagues are taking care of a patient, sometimes there'll be some differences of opinion. So I think not only do we have to communicate with the patient, we have to communicate with the other caregivers to make sure that if there are any differences, any disagreements or whatever, that we can work those out, not in front of the patient, but between us, to make sure that we go forward with a unified plan to deal with whatever the patient is dealing with. I've heard those comments about, well, if I'd only seen you a little sooner, or if that other doctor had just done this. I mean, I think that's the worst thing we can do to a patient, is to start putting that doubt in their mind and questioning whether, either someone else failed me or this doctor's already making excuses of being able to take care of you. So I think we have to communicate well and make sure that the other caregivers know what's going on and that we're all on the same page so that the patient feel that confidence that they're being cared for. But I think the other thing is that no matter how desperate things get, there's always hope. And I try to never take away that hope from my patients. I've seen miraculous healings. I've seen people recover, like Marty, that might not have expected to recover. And so there's always that hope that people can get through any adversity. But those are the main things. I think the main thing is treat them like everybody else, communicate, make sure that the patients are getting a good plan that everyone agrees with, and then be there to sometimes console, sometimes put your arm around them, sometimes just to make sure they know that you're looking out for them and have their best interest at heart. I know that we're running a little short on time, so I'll stop with that and let you ask the really interesting presenters here your questions.
That was wonderful, and I really appreciate your honesty and enthusiasm. That was great. We're going to have some Q&A. While you guys are thinking about any questions you may have, I have a question, and that is, as physicians, I think we always struggle with how do we deliver bad news to patients. And Larry touched on this a little bit and said that he's brutally honest. But as two patients who had to receive bad news and really understood what that meant, do you have advice for your colleagues, residents, and med students in the room as far as how to deliver bad news to patients?
Well, the problem is everyone is different. And so I appreciated Dr. Lilly just saying here, this is the situation, but that's so different than other people. Some people don't want a phone call. And some people want to be in the office and some people want the phone call. So I think you have to kind of feel it out. You get to know your patient, and as you're talking, you get an idea of maybe what's the best way to go about that. Would you agree, Dr. Lilly?
Yes.
Or, well, you just...
Yeah, my thought is that I guess my personality is such that if I have news to deliver to a patient, I feel like the quicker I do it, the better it is for me and for the patient. So when I started practice, I would never call them on their birthday. I would never call them on a Friday night. I would, there's certain things I would try to avoid. If it was really bad news, I might try to say, well, why don't you just come by the office? And I realized that's all, that's the worst feeling in the world is tell someone, oh, I need to talk to you, but I have an appointment, 3 days from now. Come on in. So I call up people, try not to call them too late at night if it's bad news, but I feel that the timing, the expediency of the information is important and delivered in a way that continues to offer hope and a treatment plan and so forth. But I probably err on that side of being a little bit too open and upfront.
Yeah, the only thing I'd add is sort of what I shared about the experience of me being there with my wife at the same time. When we're physicians, we may have quote unquote inside information. We may ask questions that you might normally not get as a physician, but then certainly in my family, up until more recently, I'm the only one that has a health background. So everybody else in the family looks to me or looks to the physicians for information. So I think being as straight as you can really is important, and being as quick, honest, and personable is really important.
Who has a question for our panelists?
Thank you both for sharing your stories. And obviously, I got to see Rhonda up on labor and delivery all the time, and Marty, I don't think we've ever met. So can you guys talk a little bit about us as colleagues? What were the least and most helpful things that we, your colleagues, did or did not do for you along the way? I think we kept our friendship as usual throughout most of it, but I'm just, there is a fear. You're right. You mentioned it when you talked about Christina. So what were the best and worst things we did?
Thanks. I think the answer to that, and that's actually the thing I wrote down after listening to Rhonda too, is just be a friend is really the most important thing. You really do know who your friends are after something like this. There's some people who are just there immediately. There are other people that you thought were friends and they just disappear. And it's probably that they're scared to be involved or ask or say the wrong thing or whatever. But it's really most important just to be there. And most of my colleagues, most of the people I worked with were that way. They were wonderful. They wanted to know how they could stay in touch with me, how to be in touch with me. And a lot of people ask, well, what can I do? And to me, the most important thing is just be there, be a friend. I think to say what's the worst, I mean, I'd say that's the worst, is people that you really have most, that you think you have confidence in, and they're just gone. That really hurts. But to have the people around you really rally, help you, I think Rhonda stated it really well. I mean, my group was absolutely fabulous. They just didn't even ask a question about anything. I just go take care of yourself, do what you need to do. And it was 9 months that I was gone. And then, I've never really gotten back to full capacity. So they've been wonderful forever. So I can't say any more than that.
So now, Christina, I would come up to you and hug you and tell you that if you need anything or want to just talk to me, you can.
Relax, Dr. Geiser. I also thank you for sharing all that and being so vulnerable. One of the many messages I got out of this was empathy. And I hope to God we don't have to get cancer to understand empathy. In medical school, I remember they had us place NG tubes down one another so we would know what it's like. So my question is, since hopefully we don't have to go through what you two have gone through to really understand empathy, and this is a training program, how would you teach the residents empathy without having to go through such an ordeal?
You're allowed to. Do you want to?
Just imagine yourself that you have cancer and you're getting chemotherapy and you have no hair or eyelashes. Just imagine it's you.
That was basically my answer too. I mean, you just have to put yourself in that person's shoes. How would I feel if I were sitting there on the other side of the conversation? That's really the only thing. And if you get too busy to think about that, you sort of have to shake yourself and do that. Actually, while it's not totally related to this, but it sort of made me think of the other thing that I like to say is people always ask you, well, when are things going to get back to normal? And I the quick answer is, well, year and a half, you get back to your life, whatever. But deep down inside, I never want everything to be back to normal. I want there always to be that little piece of me that remembers how awful it was when I got that diagnosis, how awful it was that I was trying to figure out where things were going to go, how I had to deal with my family, how to deal with my friends. By just holding on that little bit of piece of something that makes you feel that way, it makes you step back when you're busy or you're going through your normal everyday things to remember that you really have to care about everybody else.
I think the pace of medicine today really prevents us from slowing down and remembering every single patient we're interacting with that day is struggling with something, has gone through something. We need to be empathetic with each patient we see. So, you know, hopefully Rhonda and Marty can help us remember that it's a real privilege to do what we do and to slow down and really have that human interaction with each person we face each day.
Just one other thing. I think everybody thinks of ways that, you know, they can contribute afterwards, you know, how they could, you know, some people, it's like they got to do something big and splashy, like, you know, have a fundraiser ball or something like that. For me, the most important thing for me is to actually connect one-on-one with people who are going through this and being able to answer their questions and help them understand you got to take it one step at a time. And because it's just so easy for your brain to go to that endpoint, and just tell people, just take a step back and just do it one step at a time. And you're right, you know, you just get so busy, sometimes you just forget about all that and just do it every day. Just say, let's stop here. Where am I? What do I need to do to do the right thing?
I remember the day, it was a Friday, and Marty called me in the office because I had done a PAP on a patient. And I didn't know if it was important or not, but in the comments section, I wrote, patient just underwent a bone marrow transplant. He called me up to discuss that PAP. It was just a little abnormal, but that's how I learned about Marty and his history, because I think that particular case, talk about resonate with you. He said, be sure when she has her next PAP and when she has her colpo that you put these to my attention. So, any other questions? I'm going to make a plug and say, if anybody likes what we're doing with these MEDTalks and you would like to get involved and you'd like to help with planning of future MEDTalks, this is not a big time commitment. We meet 3 or 4 times a year. You get to sit down with awesome people like Drs. Lily, Geiser, and Kelston. But if you'd like to be involved, reach out to myself or Jason. Lexi Steins does all of the heavy lifting for this. She arranges for the CME, but if you'd like to get involved, please let us know. And I think that goes for nursing and residents as well, not just the attendings.
And just to close, I would like to thank our speakers for sharing their stories and remind everyone that, you know, these are 2 people that you know about who are going through or who went through struggles. You probably pass more in the hall and don't even know it. So just keep that in mind. You know, one of the things that we all have in common, everyone in this room, is we were all dumb enough to go into medicine. There's a lot more money in other fields. There's a lot more time in other fields. You can be a computer person and live a very nice, healthy life and go home to see your family at dinner, but we've chosen not to. So remember that there are those stresses that you might not be able to see. So if you do see someone who looks a little bit off or a little bit stressed or a little bit more tired than we normally are, ask, how are you? Is everything okay? Is there anything we can do? I think that's one of the things that I'm trying to get across to the members of the medical staff, is that we are all members of a fraternity/sorority that is an amazing privilege, but is not easy. And it can take a toll on people. So remember that when you're walking down the hall. If you see someone who's not as bright as they normally are, smile, ask them if they want to grab a cup of coffee. If you need to, come to me and I'll put it on the medical staff tab. So thank you all for coming. We will be doing these more regularly. I will try to be better at promoting them. And a round of applause for our speakers, please. Marty's going to close us out.
The only thing I'd add along that line is you don't have to have cancer to have a bad diagnosis and have a lot of these issues. We all know there's a lot of bad stuff out there, and people have serious illnesses, and it impacts their life in a very similar way. So just remember, we're all people.